Hey everybody, I'm Dr. Scott Worden, the TOS guy, and we got some good news and bad news today for our next live stream. Start with the bad news. Unfortunately, Dr. Farid Gharagozloo had an urgent call to surgery and won't be able to attend. But the good news, of course, is that we have one of our more frequent flyers here, the TOS expert physical therapist, Steve Talajkowski. Steve, I know you've got some good stuff for us today. I look forward to your talk.
Hey, thanks, Scott. Thanks for having me back. So the talk today was going to be about the limitations of like standard physical therapy with a thoracic outlet, and we were going to talk about some of the problems patients have when they get physical therapy. And I'm hoping to do is sort of introduce you to some concepts. We're going to have a case study later, but just kind of help people to sort of identify when they're having trouble with their physical therapy and, maybe learning to kind of ask the right questions of their physical therapist as to how they can help them. So if you guys remember, I use the INVEST program that was developed by Peter Edgelow, a physical therapist out here in Hayward, who I worked with for 14 years. The INVEST stands for the Edgelow Neurovascular Entrapment Self-Treatment Program. It's also been called the Neurovascular Entrapment Syndrome Treatment Program. So both of those terms have been used. If you've seen some of the past videos I've done, I'm going to go through a real brief kind of the sort of basic concepts of the INVEST program. There's the ABCs. This is Peter's idea. The A stands for activate the core. We're talking about posture and also moving the body on a stable body. Breathing, which is going to be part of what we talk about today as well. And it also involves awareness and managing stress. And then cardiovascular exercise, which is movement. And I would say movement with intention. It means you're being aware of it. Just remember, thoracic outlet syndrome is a neurovascular entrapment problem. So what we're looking for is to open the space where the compression is happening. So another concept that was very simple is if you want to relax the muscles, relax the muscles, open the space, and calm the nerve. What's important is that exercises should not aggravate the patient's condition. The exercise program is progressed or exercises are stopped by taking and assessing objective measurements. I'm going to start with the case study. This is a pretty common patient. The age isn't that common, although I do see a number of teenagers, but the information is pretty common. So we have a 13-year-old female, excellent health and fitness, a competitive swimmer, swimming at almost 25,000 yards per week, no previous symptoms of TOS, and just had a previous unrelated injury to her left shoulder, tendonitis, rotator cuff, sort of common for swimmers. Well, about 2 years ago, the patient jammed her right hand into a wall while doing a flip during a meet. They did take x-rays, which ruled out a broken hand. And over the next 2 weeks, her hand symptoms started to improve as the patient continued to train. However, during this period, the right hand and arm began to feel numb. She started to have tingling in the fingers, right shoulder pain, which experienced in the front of the shoulder. But she continued to swim. However, the symptoms got worse. So she took a visit to a sports medicine doctor here in the Bay Area. And the doctor did an assessment and gave her a diagnosis of a neurogenic thoracic outlet syndrome. The doctor prescribed a handful of daily exercises, including above head stretching with resistance, arm to side stretching with resistance, and ball rolling directly on the area of the soreness in the front right shoulder, that kind of the ball in the pec minor. The patient is 100% compliant over the next 3 weeks, and all symptoms worsened during this time, especially the numbness and tingling. During the patient's second visit to the sports medicine doctor, the patient's referred to physical therapy. So this is April. So the PT assessment on the first visit is using the thoracic outlet diagnosis. The therapist does ask the patient to eliminate their arms from swimming, and rather instead they just hold on to a kickboard and use feet, their legs. The therapist uses massage therapy to begin each session with moderate finger pressure and massage directly to the area where it's painful in the front of the shoulder. Kind of similar to the ball, but not as intense. The patient's instructed to do her own self-massage at home. There's some moderate stretching, and the patient again is 100% compliant over the next 5 weeks, including no swimming. But again, the symptoms continue to worsen. So the patient's family seeks a second opinion from some healthcare clinicians with extensive thoracic outlet syndrome experience. The patient completes a specialty MRI for TOS from NeoVista MRI, a Scott's company, and the exam indicates moderate bilateral thoracic outlet on both sides. And then the question is going to be did the right side trauma, or actually the right side trauma did lead to the start of thoracic outlet? So at this point, I've come in, and so in June of 2019, the patient starts to see me. So the patient was advised to begin the Edgelow method, or the INVEST program, and to stop the exercises that the other therapist gave her. So the patient stops her all activity at home and work and school, except for what she needs to do, for 6 weeks. In the introduction to the first INVEST program, we introduce breathing and stress reduction as part of the program, and in this case, it's effective. And after 3 weeks, we do some additional steps. This is all in the first group of exercise, including the pinky ball for first rib mobilization. And the patient begins walking and moderate leg workouts. At 90 days, the patient begins more intense lower body workouts, and not long after begins the kick workouts in the pool, again holding the kickboard with limited arm movement. By this point, the pain is essentially resolved. There's moderate tingling and numbness in the hands and fingers intermittently. By October, the patient starts to introduce limited arm and shoulder motion into her swim workouts, and if she has any symptoms, she immediately does or stops and does her Edgelow exercises. By November of that year, she competes in 2 short swim events for the first time in 6 months. She continues to swim until the COVID, when the pools close. So back last year in the pool by July 20th, she has very occasional and moderate symptoms. And when they occur, again, she stops and moves on to the Edgelow INVEST exercises. The patient, now 15, reports being approximately 70% better of her pre-diagnosis capabilities. She's swimming 15 to 16,000 yards a week. Most flares track to a combination of posture, stress, and sleep positioning. And I've heard that she's had some of the best times in some of the short competitions that she's ever had. And then she's viewing the TOS as management program, and that it's a continued learning process. But in the pool, she's competing at a high level once again. So what I take from this case study, which is very common with a lot of patients I see, is while the patient was found to have positive findings on her MRI, it was actually the injury that triggered her TOS symptoms. This isn't always the case, but it can be the case, and I think sometimes that injury sort of clouds the information. So the focus might be on the injury and not the TOS. The patient was fortunate to quickly get the proper diagnosis, both from the doctor and the physical therapist who was treating it, but still received the wrong treatment plan for her condition. The program given by her doctor and later her physical therapist aggravated her symptoms. That's not the problem. The problem was that it wasn't appropriately modified. I mean, I wouldn't have started with those exercises, but I think the fact more is that if you do something and it makes the patient worse, you have to change it. So while symptom aggravation can happen, it's important to modify the patient's program quickly. The TOS exercise program is not a no pain, no gain program. What's also evident from the case study is improvement takes time. We were looking at almost 6 months before the patient was able to go back and compete and swim competitively. But I'd also say the patient is expected to see measurable improvement soon. I think in this case, with the patient being 70% better, I think there's still room for improvement. I discussed this with the patient's parents recently, and I think if I would suggest that the patient just continue with the Edgelow program and not necessarily wait for symptoms to get worse. I think finally is that in many cases, the patient will require a lifelong changes to their working habits, their exercise program, postural awareness, and stress management. But I kind of view these as all positives. I think most of us, if not all of us, need to address these healthy habits and exercise programs. And so I think it's a good thing to start this stuff sooner rather than later. So I think that's all I have for the slide program.
Thanks, Steve. I think those stories are very helpful, especially in a young, healthy person like this. Do you see a lot of young athletes?
I have a few young athletes right now. And I have to admit, most of those patients or athletes do well. I think what makes it probably a bit easier is that they tend not to have a lot of secondary issues that maybe an older patient has. Now, there are cases where I think I'm being sent a younger athlete with the idea that the INVEST program may help them, but it may also sort of give that person a conservative treatment approach first, and that if it doesn't work, then maybe surgery is another option. So I also have some younger athletes who would eventually get surgery. But I think the idea was to try the INVEST program first and see how far it can take them. And in cases, the INVEST program is enough. In some cases, surgery is a possibility.
Do you see some of these patients after they have surgery for TOS?
I do see some patients after surgery. I think it's part of it is location. So I have patients that come to me because I'm one of the few people in the area that can treat thoracic outlet. So people will come from me from a distance, and then once they have surgery, if they're closer, they'll come back to see me. Sometimes if they're further away, the doctor will just send them to a local therapist just because it's just easier. But I certainly do see patients, and I think it's important after surgery to have physical therapy and to sort of adhere to the same principles of not aggravating the condition, measuring things objectively, giving it time, and not being too aggressive at the beginning. That's been my experience. But the expectation is that they would progress, I don't know if I would say 3 to 6 months, but that would not be an unreasonable goal.
So that was my next question. Even after surgery, they shouldn't get involved in a quote unquote standard physical therapy. They really do best when they have a dedicated TOS provider.
Yeah, I think so. I think in some cases there's some things that are eliminated. So I think you can be a little bit maybe not as careful. But at the same time, I've had patients that have come back to me that have gone to a therapist and they've been too aggressive, and they decided to take the trip back to Hayward because they felt they weren't getting the results they expected.
Very reassuring. I'm going to start asking a few questions. We have a first one here. Dana in Canada asked, why would a ball rolling on the front of the shoulder worsen the pain in this case study.
Yeah, and I've seen this other patients. I think the idea is it's usually a pec minor release. So if there's a feeling the pec minor is tight, and if you just if you massage over the pec minor, you're going to get a release of the brachial plexus. What seems to be the case, though, is it's more of a it just seems that you're putting direct pressure on the brachial plexus and you're just irritating it. So I think there's other ways to stretch the pec minor. I think there's other ways to open the spaces, and I think you got to be careful. I mean, one of the assessments when I see a patient to start is I'll palpate the pec minor to scalenes, and in a lot of cases it's very tender, and to just keep pushing on that more and more, I think, is just a mistake. But ultimately, what tells me that something is wrong, or what should tell any patient that something is wrong, is that they do it and they feel worse. So when people ask me, well, should I do something, and they say it makes it worse, I kind of just say, well, then don't do it. And it almost seems obvious, but I think we're used to this no pain, no gain philosophy, and I just feel like in this case, that's not the philosophy that works.
So when you have a patient who you have empowered, educated about TOS, do you feel, from all your experience, that they are better able to handle those flares that come up after they've seen you and after they've gotten back to normal life?
Wait, so kind of rephrase that again. I wasn't quite sure if I got.
When you've seen a patient, you've educated them and empowered them with this knowledge about what's going on. As they go through life after that, and let's say they're back to 80% or 90%, but they do get flares. A lot of these patients who don't get surgery will get flares from a particular activity. Do you find that the patients who are more educated tend to know when those are coming on more quickly and know how to address them with a positive attitude?
Oh, I mean, that's part of the program is to prepare people for the future. And that comes up especially towards the end of their therapy sessions when I'm finishing up and getting ready to discharge somebody, is to kind of prepare them for the fact that, you might be better today, and 5 years from now something could change. You could have a change in your job, you're moving, life is more stressful, you got a family, you're exercising less, and all of a sudden your symptoms return. I have repeat customers. I have people that I've seen 5-6 years ago come back to me, and it's almost always the same story. I was doing fine for a while, and then I just kind of slipped back. And that's true with a lot of things. It could be a diet or just a health exercise program where you just kind of get busy and forget. So in those cases, a lot of times people come back just for like a refresher, a kind of a kickstart. We usually get them going pretty quick, and they can get back on track again. So I don't like to see it, but at the same time, I'm glad they come back, because I think we can help them, and I think they feel like that's they just need a refresher.
Refresher. I like that word.
But I do see people, and I've talked to people at the same time, and I've been doing this for a while, and you hear from people, and it says, yeah, I've been doing these exercises for 10 years, and that's why I'm still working.
It's great. You're great. You get people through this without surgery. A lot of them get back to nearly normal.
Yeah, and I think, if you look at even the case study, and this patient, and I just asked her father recently, like, where does she think she's at? And she's 70%, and she's still swimming.
A very highly competitive swimmer, really.
So I tell people, and I think the expectation is I want to get 100%, and I'm thinking I don't even know what 100% really is, and I know what they're saying is they want to get back to doing their normal things. Mm-hmm. But you can get back to doing your normal things and not be 100%. But I think, and also in the case study, is if you're going to be at that level, you're going to have to do something to maintain it. I mean, probably for forever, but it doesn't have to be a burden. It's no more of a burden than brushing your teeth or taking a shower every day, or whenever you take a shower, you just do those things.
Well, it is a little different because most people brush their teeth every day, but you
Right.
don't know when these flares are going to come on.
Right, but I'm arguing is that you could kind of have some kind of a program where there are people meditate and they do yoga. So I think there's this feeling there should be an ongoing exercise program. And again, I think it's because if you get into this ongoing program, it's because you need to have an ongoing program. People say, do I have to do these exercises for the rest of my life? And I say, if that's what keeps you going, then you have to do them for the rest of your life. And does it mean I have to do 2 hours a day? I say no. But you have to be aware. And the idea of incorporating the breathing and the posture and the exercise into your daily activities where it becomes you, it becomes less important to lay down and do an exercise, for 20 minutes. Because the posture and the breathing and this whole approach to your activity is sort of automatic. It's part of who you are. So it's not an exercise program anymore. It's who you are now.
That leads to an obvious question. When you're dealing with an athlete who's at this level, their base, their posture is going to be pretty finely tuned. Do you find in most cases that's a help that gets them through this more easily?
Athletes are tough because I think on one hand, they're used to experiencing discomfort and pain. They're used to pushing themselves. So it's sometimes harder to get them to listen to these small problems that I think are telling them that they're flaring themselves up. But at the same time, I mean, athletes are like people. I'm sure there are definitely people who are very in touch, and they'll like the Tom Brady's, they'll eat certain foods and they'll have this very disciplined technique and exercise program and diet, and they won't waver from it. And other people just push, and they work through it. So I don't know if there's like a complete athlete profile, but I have had some issues with people that are very active and fit, where I think they just want to push through it. So I think we got to be careful. What I mentioned earlier, and I kind of briefly talked about it, but I think I talked about it in an earlier video, is we do these objective measurements, hand temperature, shoulder range of motion, strength, grip strength, thumb strength, where you can see changes in your strength just from being flared up or being calm. So it's no longer just a strength issue. It's a nerve entrapment that's leading to a strength deficit. If you can reverse that, you're automatically stronger. So it's not a matter of just being stronger. It's a matter of taking the tourniquet off the nerve, or the brachial plexus and vascular system.
You and I talked about this a few years ago. There's a now retired hand surgeon in San Diego, Dick Braun, who used to do scaling injections. And before and after the scaling injections, he would get the patients on a BT machine, right? And he'd measure their work product. And he noticed in a lot of patients significantly improved work strength afterwards, as well as better oxygen saturation in the fingertips.
Oh, I had a patient just a couple of weeks ago that got injections, and her grip went from 40 pounds to 80 pounds.
Wow.
She couldn't believe it. And so it wasn't a matter of strengthening that changed it. It was a matter of opening the space.
Right. And, to tell you the truth, I've reviewed this literature, and it's really not clear at all to me why scaling blocks work. I know there's some docs out there who do them a lot as an indication for going to surgery. Some of the earlier papers from Los Angeles said that if you got a scalene block and you felt better, that you would do better at surgery, but it wasn't a controlled study.
Right.
They didn't take the patients to surgery who didn't have the response. They didn't know where the needle was from their guidance. It was just a interesting factoid, which still to this day hasn't been really examined. And I think the reasons why it improves patients are not clear. For those of you people who are listening, I've done these injections. I know lots of people who have, and I don't think there's any doubt that a lot of patients respond to these blocks. But I just don't think that any reason anybody gives you right now is a good scientific reason. And until we know that, we just have the fact that it makes some patients feel better. It doesn't mean it's a higher chance of success at surgery. So I would take those with a grain of salt. I'm going to interrupt my train of thought right here because they have another question from New York, from Gina. It says, you mentioned the hand trauma during this case history. Do other forms of sports activity cause TOS?
Oh yeah, it seems to be the overhead sports. I just patient today, matter of fact, who's a tennis player. I spoke to him. So tennis, baseball. So throwing sports like baseball, swimming is a big one. So anything that's kind of overhead and compressive seems to be the case. I'm sure there's other things where you can have like a football injury, but to be honest, I'm trying to think of a football player I've seen. And then there are sometimes I see people, it's kind of a gym injury where they're really pushing their reps, their weights, doing things like pull-ups and bench pressing, things that are just.
And the lat bar?
Yeah, and I'm sure it could be, well, yeah, and I guess when I'm talking about what the person's describing to me, I don't really know what caused it because sometimes their pain comes on later. But I would think anything that when people are doing sort of these, like they're taking themselves to a level or two higher, or they're trying to compete with somebody else, that sometimes they just have trouble with that. But going back, again, overhead sports injuries are the most common. And then again, some of the kind of the like the 20-year-old, 30-year-old people who are in the gym, just working maybe too hard for their level of for maybe they're just not there at that level where they can safely do those exercises.
I can add to that in my experience, my knowledge of the literature, we really don't see many football players. You might expect a quarterback would get that, but quarterbacks throw the ball, 30 times a game, maybe 40.
Yeah.
Any more than that would be an unusual game. And a lot of those passes are not full speed. The vast majority of them are not full speed, right? Whereas a baseball pitcher, between warm-ups, before the game, warm-ups between innings, and then official pitch counts during the game, many pitchers can reach over 100 pretty much full speed throws during a game. So in the literature, it's come out a lot in the recent couple of years, let's say 5 years. We've seen a lot of baseball pitchers at the major league level and at the higher minor league levels being diagnosed with TOS. The volleyball players, they tend to do overhead, but not nearly as much as swimmers. And I expect we're going to see more awareness of this in swimmers, just as in Major League Baseball, the awareness has increased from pretty rare to fairly common now.
Right.
I see this probably twice a month. I'll see a minor league pitcher show up with a diagnosis. Now, I don't know if that's the correct diagnosis. We were basing this on media like ESPN, but it's way more common than it used to be just 10 years ago. And there was a famous story. You can look up the guy, J.R. Richards, big 6'6" tall African-American pitcher, a right-hander for the Astros. And I think he won Rookie of the Year. And basically, his pitches were either a fastball or a faster ball. I mean, the guy could throw hard.
Yeah.
And he started complaining, I think, in spring training of his second year, that his arm was weird and tired. And he got put off. He got blown off. And a A lot of the sportscasters didn't treat him very well. They just, he's lazy, he's not trying hard. And then all of a sudden he had a stroke. And it was because he had TOS. He had a blood clot in his veins and no one recognized it. And he never pitched again, which is an unfortunate and sad story. Now, that's not neurogenic TOS by itself, unless it coexisted. And we don't have tests at the time to say that it was. But clearly what showed up is a blood clot and a stroke. It's really unfortunate. Now, that's pretty rare. For all you people out there who think you have TOS, a stroke is pretty rare, especially nowadays. And it usually comes about with venous TOS, where the arm swells. You'll have veins pop out over your arm. The arm will change color to blue or purple, so you wouldn't miss it in most cases. And with my cohorts like Steve, our challenge is really the neurogenic TOS. So we don't do a lot of MRIs or examinations of patients with venous TOS or arterial TOS. Those things are usually recognized in an emergency room or by your personal doctor pretty quickly. Steve, another question here. It seems like most physical therapists don't understand how to treat TOS. Why is that? And this is from James in Orlando.
Yeah, I ask myself that all the time. I'm dead serious. I ask myself all the time, even in my own clinic. I will have some of the therapists, and we have 5 therapists in my clinic, and they're asking me to see patients sometimes. I think it is still a bit of it's a niche. It's still not, well, I think it's more common than we think, but I still think it's not common. And I'll probably talk to some patients, therapists, and they may only see a couple of thoracic outlet patients in a year sometimes, where I might see 6-7 people in a day, because people come, they know I do that. That was the same with Peter at Edgelow. When I was working with him, he went from 5 days a week to 3 days a week, 2 days a week, and 90% of those patients were thoracic outlet. And then as he started to work less hours, all these patients needed to see somebody, so I was starting to see them. But I think it's just not that common, so therapists don't know what to do. I think there's overlapping conditions that confuse people. So if you have like a younger therapist, and I'm not saying it's just younger therapists, but sometimes it's hard to figure out like what's really going on. I think it's a tendency you got to be patient, because I think the progress is slow. And so it's not normally the 2 days a week, 3 days a week kind of a program. It's more like, I'll see you this week, I'll see you next week, and then come back in 3 weeks. So people don't sometimes even operate that way anymore. They kind of are used to the twice a week thing. And I think therapists fall in the same trap as patients. We need to push people and motivate them and get them going. And I think the therapists sometimes push too hard. And then there is a whole nerve glide approach out there that's people, they see the nerve glide thing, and that's the first thing they start doing is nerve glides. And oh my God, that's the last thing I start with.
The nerve is inflamed. Yeah.
Yes, but people, the thing they know about nerves is the nerve glide. So then you start doing the nerve glides, and then you're thinking, so it's kind of what they know. So, I mean, if you ask me about a burn patient, I wouldn't have the first idea what to do. So part of it is just inexperience, even with experienced therapists, and not seeing enough patients. And I think that's my where I get my benefit from is I've seen 1,000 patients, if not more. I mean, and every time I see somebody, I learn something, and I'm being totally honest with that. I learn things every day, and I learn it from my patients.
This is why I call professionals like you to pick your brain with the other experts around the country. There's a lot to learn in this. And the awareness issue that you raise, where people don't see it. So a patient goes to their physical therapist or their doctor to get an opinion, they count on that person to know. And if that person isn't aware of this disease, or They say, well, it's disputed. Let's not talk about it. It's unfortunately a disservice to the patient who places that trust in their therapist or doctor. I'll read you a quote by Henry David Thoreau. He said, and I just found this quote the other day. He said, it's not what you look at that matters, it's what you see. So there are physical therapists before you that look at the same patients and they do nerve glides or they say strengthening, and they don't see what you can now recognize after thousands of patients as a clear pattern of TOS. That's meant to be a compliment, when you earn this position.
Yeah, no, I said I'm fortunate. I'm thrilled to have patients on my schedule that have thoracic outlet. I mean, thrilled because not because they're I'm sad because they're suffering, but I feel like I can help them.
You can make a difference in their lives, right?
So if I see somebody on my schedule, I'm thinking, thank God, my light just died.
Huh. We have another question from Aaron in Miami. Hey, Aaron, sure. Is bench press, even with lighter dumbbells, still something that should be avoided? Or is there actually some benefit to a controlled and not too heavy bench press?
I don't honestly see a benefit.
And he added a little follow-up, so let me add this too, Steve. Including perhaps some stretching benefits to the pec major or pec minor. What are your general feelings on this?
Yeah, I don't see a benefit to it. And again, I think you're asking yourself, like, well, I always ask every patient, why are you doing this exercise? And for example, let's say I'm going to do a bench press to stretch my pec minor. I says there's so many ways to stretch your pec minor that don't require a bench press. Matter of fact, I don't even do the doorway stretch. There's ways to stretch the pec minor for a kind of a flared up patient where they can be lying down with their arms at their side. I use a sandbag, or you can use a manual stretch. And other part is, I don't really want to strengthen the pecs. I want to relax the pecs, if that's what I'm trying to go at. Or I want to relax the scalenes as well. So I don't think forward movement is the direction to go. If anything, I'd be doing more posterior exercises, scapular retraction, rotator cuff, external rotation, middle traps, lower traps, muscle re-education stuff, rather than trying to get stronger.
And so you would do these without weights because you have much more control than
do without weights, or if you're and again, strengthening is like if I had 5 steps to the program, strengthening is like one of the last steps of the program. We're talking, I had a conversation again with this patient today, and I'm looking at, unfortunately, like 5-6 months. And you can even kind of look at that with the swimmer case study. I mean, it was 6 months before she started to swim. I mean, I'm not saying she didn't do anything, but I would still say it's your symptoms dictate what you should do.
And to be optimistic, this person has broken some personal records, really made some progress, but she really had to take a step back.
She had to take a step back, right.
Which is hard for a young person, an athlete, when they're pushed so hard.
And like what I heard is that she's had some really good times recently. And if you even look at the yardage that she's swimming, it's less than what she was swimming before.
So less practice, better results.
Right. And maybe a more focused practice, and maybe a focus on breathing,
right?
Technique, and a focus on posture is maybe more effective than just pounding out miles or yards in this case.
So in short, for Aaron, and again, Aaron, good to see you. Thank you for the question. You would say,
I gotta get my charger. My computer's gonna die, so I can hear you.
Better get that. So, Aaron, thank you for the question. I think Steve's answer is that weights don't allow you as much control with your muscles, and you have to be very sensitive to what's happening. This kind of biofeedback, I call it, but obviously paying attention to your body posture and what's happening is one of the things he teaches everybody. So until Steve gets back here, and I think it'll be soon because I hear him rustling about.
I am back. I just got to plug this thing in.
All right.
Sorry for the the light going out too.
No trouble. Computers run out of battery all the time.
Thought I had that taken care of. Here we go. Okay.
Okay, so we then have a question from Jim in South Carolina. He says, how do you find a physical therapist that will use these methods that are specifically for TOS patients?
I don't expect people to necessarily find a therapist that was trained in the INVEST program. I mean, Peter had taught all over the country, but I would probably guess that the last time he taught Peter's passed away. It'll be 3 years coming in June. And he was retired for 6 years before that. So I'm guessing he probably hadn't taught for, could we go 12 years, 13 years, maybe even longer. It's been a while. So I wouldn't expect people to necessarily know the INVEST program. But what I was hoping today was to talk about this idea of avoid this no pain, no gain approach. Expect that at the beginning it needs to be slow. The focus has to be on relaxing muscles, opening spaces, calming things down. It doesn't start with nerve glides and strengthening. So, and if you start feeling worse, it's not working. And it's not okay to make it worse, but I mean, I might do something that makes a person worse. Maybe we might progress to the next exercise in the INVEST program and the person can't do it and we stop it. I don't say just keep working through it and it'll be better later. I say you got to stop it. So when you're with the therapist who's pushing and maybe not listening to those problems that you're having, that's not the right person to be working with. There's got to be other people that treat this because there's a lot of thoracic outlet patients in the world. And my guess is if the INVEST program was the only way, well, then people are in trouble.
Well,
and there's even people in the area. I mean, there's people.
See, you're happy to talk to people on the phone and by video.
Sure. Oh yeah, I have I mentioned him a couple times. I have a patient who's on he was in Florida today, so we're talking on Zoom. And one of the there's certain kind of there's like Feldenkrais. I'm not saying they treat thoracic outlet, but that approach of like small movements, controlled movements. I have some patients that are doing some mild fascial work, but it's in a very respectful, gentle way. So I mean, there's got to be other patients or therapists or clinicians that are treating patients. I know there is, but they have.
Are you willing to do a teleconsult with them?
Of course,
if
always.
They want to.
Always,
are you willing to speak to patients' physical therapists to kind of share what you do?
Sure.
Okay.
And someday I'm going to start teaching this, but.
Well, I can vouch for, I've sent several patients to Steve, including this patient we both know from Florida. And they're tough. They don't have someone locally who's helped them. I think, Steve, you're not really telling the whole story. This was a young man who was an athlete, an overhead athlete, a tennis player. And he went to the Mayo Clinic and Johns Hopkins and a bunch of big name places, had a lot of trouble getting the diagnosis. And then we helped him get the diagnosis. And then he saw you once by traveling across the country. And now you're seeing him through teleconsults, and he's definitely making strides when I've spoken to him.
He's better. I talked to him today. He's better.
And that's great news. I love that. So I encourage all patients out there who think they might have this or have been diagnosed with TOS. It's worth a chat with Steve. It's worth considering that teleconsult, or if you have a physical therapist you like at home, you might at least expose them to what Peter did and what Steve has advanced in that field. And Steve's such a nice guy that he'll talk to anybody. And sharing his knowledge will impress people. They'll probably do a bit of reading and maybe they'll be better at it, and that'll help the next person down the road. Our next question. Oh, and by the way, if you want to get in touch with Steve, we're glad to do it through our website, through tosmri.com. Just come and contact us and we'll put you in touch, no trouble. Another question says, random question, can cell phone use cause TOS? This is from Donovan in Pacifica. And I'm tempted to say, if you have one of those really old cell phones that weighs 5 pounds, that might do it. But in the meantime, not to joke or make light of this, Steve, what do you think about cell phone use? Is it this posture that people tend to use the same hand and tilt their neck and do that? Does that?
Yeah, I mean, what I'd say with the cell phone use cause it, I would probably say it's not the cause, but it'll certainly aggravate it.
Mm.
You know, and I think it's, you know, you're looking at just using devices. So, you know, you get the person, and I have a lot of patients. Got a patient yesterday, a new patient, just a software engineer, programmer, and she has thoracic outlet symptoms now. But then you kind of include, okay, so I'm at the computer for 8-10 hours a day, and then I'm on my cell phone for the other 2 or 3, and then I'm on so the stuff all adds up. And
it's a great
so
point.
I guess if you're on a phone for 12 hours a day, yeah, it could trigger it. But like most people, it's like it's a combination of the phone, the video games, this computer, working on your and you know I'm seeing patients now because people are working from home,
Right.
and they don't have the same ergonomic setup that they may have had at an office, and now they're on their literally. I've had people tell me they're working in their bed.
Wow.
And I'm thinking, you can't do that.
Well, I think you're raising a great point. We assumed, thank you, Donovan, for the question. We assumed that they were talking about this, but you're right. A lot of cell phone use is this, or laying in bed and kind of doing that. And it's worse, I've noticed personally, with tablets. So I spend time in my office trying to be ergonomic, and even there, even with the amount of brain cells I devote to TOS, I still find myself in unergonomic positions. For 15 minutes at a time, I'll say, what was I doing?
Right.
With a tablet, my iPad, I rely on my tablet a lot for consuming, for reading particularly. And there's never an easy way to hold it up in front of your face and have good posture for any length of time. It's too heavy. I always have, my elbow propped down, my head turned one way, then I switch, but it's nowhere close to ergonomic. And when you watch people use a cell phone, it's not just the talking part that's unergonomic, but when they're playing games, their head is down. Or if they're laying in bed, they're probably doing just what I did with the tablet.
Sure.
So
and it's
of computers, I think, has just spurred on this rash of what we think is TOS in a lot of people.
Exactly, and I think that the fact that we see everybody doing it, we just assume it's okay, and the fact is, when I see patients with syndrome, and I realize that they're just more susceptible to these postures and these positions, and it's a little bit unfair, but I think if you have that problem, you have to be more careful, and just because everybody else is doing it, and I would argue just because everybody else is doing it doesn't mean everybody else isn't suffering in some way. But people with TOS are suffering way more, and if it was just pain and you're dealing with it, it could still work. That's one thing, but when I have patients that are literally off of work because they can no longer work on a computer for 8 hours a day. They can't work on a computer for 30 minutes a day sometimes. At that point, you gotta change things.
At least Darwin's version of evolution, I don't think it had to deal with cell phones and all these other devices.
I think the first iPhone was 2008.
Yeah.
So that's the beginning of
Changed our world.
What we have, right? And now it's like you can't live without it.
So we have a viewer from England, Teresa.
Really?
And
Cool.
she says, if you could share the top 5 things that a patient should know about TOS, what would those be?
Um, I would say is, well, I kind of trying to think if I could number it in 5, but kind of just reiterating what I was saying is, don't fall into the trap of aggravating your symptoms or thinking that that's normal. Exercise at the beginning has to be gentle, easy. And I didn't talk a lot about specific exercises, but the very first exercise that we teach in the INVEST program is learning how to diaphragm breathe to relax the scalenes. And this is done lying down. So the goal there is to focus on scalene relaxation and breathing. And then as soon as you're done assessing whether your symptoms or not your symptoms, I'm sorry, is there some objective change? Hand temperature, range of motion, shoulder, neck. So I think this idea that you need and I emphasize this day one, you need a way to objectively measure whether you're getting better or worse. You can't use your numbness and tingling, your pain, your symptoms to measure improvement or worsening. You have to measure it objectively. And those methods are way more sensitive than numbness and tingling and pain. Remember I said about in the ABCs, we want them to walk, we want them to do something vascular, because most of the patients that have trouble, we're not talking about the athlete, but just people that have computer jobs, they're sitting all day. We're sitting all day, we're commuting, we're sitting home on our desk, our couch, we're laying in bed. So cardiovascular activity is important. And at some point, we need to work on the core. And the core is helpful for so many things. It's helpful for the breathing technique. It's helpful for stabilizing the spine and the scapula. And so core exercises are important as long as they don't aggravate. So when I see people, we don't work on the core day 1 or visit 2 or visit 3, but it gets thrown in there at some point because you need to have strong core. And I'm not sure if that was 5 or not, but
There was more. There's a whole lot of tidbits in there.
But don't aggravate it. If there's number 1,
Good. Don't aggravate it.
stop aggravating it. And if something you're doing is aggravating it, you got to stop.
I think one of the things you left out is that they should come to toseducation.org and watch our guest speakers like you more often.
Yeah.
That would be one of the top 5 things. Learn about TOS.
Yeah, you're right. Yeah. And right. Because I mean, the program is really teaching the patient, how to treat themselves. I think I mentioned that very first slide. It's the Edgelow Neurovascular Self-Treatment Program. Mm-hmm. So it's really the patient learning how to
self-awareness.
Exactly.
So I think that's great, being just aware of TOS. A lot of people don't know what it is. When I get patients contacting me, Steve, it's fascinating the number of stories I hear that are different about how they even happened upon TOS. Sometimes it's a doc. A lot of times you'd be surprised it's a physical therapist more than a doc.
Right.
Other times they hear about a baseball player. Other times they can't even remember how it happened because it took them years to find us. And that's one of the things I'll say to all our viewers as well. We're working really hard through experts like Steve to provide educational information, but this doesn't start for anybody until we raise awareness. So for people who are members of Facebook groups, et cetera, where people like me are excluded, I won't go into why. Well, seriously, there are some groups that don't want to have physicians on board so patients can talk and share freely. And it's important to share knowledge of TOS when patients show up there. Hopefully the patients got there. But outside of groups like that specifically fall under the aegis of TOS, we're hoping to raise awareness through social media. I know my group, TOS MRI, we're on Instagram and Facebook and YouTube and all the usual channels. We want to help spread that word so that the person who's just having neck pain and arm pain finds that out early. They consider TOS, whether they have it or not. But just to come to that possibility is really important. Steve, I don't know if you've had patients share stories with you about how they got to you. Do you see patterns, or do you see a way that we can help raise that awareness?
Oh, it's kind of like you said. It's just all over the place. It's I have had patients who have heard things like this, and actually they're the ones who told their doctor to refer them to me. But I think it ends up that it's this idea that over time, and I think it kind of depends on what system you're in. If you're in a work comp system, like I see work comp patients in California here, it's sometimes hard for the patient to sort of direct their care because they're kind of held back by the whatever system they're in.
Right. Patients have to advocate for themselves.
They have to advocate for themselves, and I think it's I think people people hear something, then they hear something else, and someone tells them something, and then they kind of find out. And other people, so you have to advocate and look. And the problem is, I don't know how you look necessarily, because the web is so massive. And I'm sure that there are people that are stuck and don't know where to go even today. I mean, it has to be. So it's sort of a bit of luck. Sometimes they get the right patient, the right doctor, the right therapist, and the right
parents.
Yeah, the right parents.
By the way, we just had a lower third on here from Marion Zubak, who said that she shared our information with her TOS group in Canada and these sessions. Thank you, Marion. That's really important. We really appreciate that. I could share a story about, and I think I've said this before, I got a call from a local hand surgeon who's an amazing guy, a musician on multiple instruments, really great hand surgeon. And he speaks very quickly, and he just connected me with a patient who was in his office. He does this a lot, and it's kind of cool. Patient was a mom who was an RN, a registered nurse, at a big health institute in this area. And I'm not going to mention that name. And her son had been struggling with arm pain, and he had a full scholarship for a great music college on the East Coast, but he couldn't follow it because he couldn't play. And the doc at this large institution had said, I can cure him, just has to stop playing, which, didn't thrill the patient or the parents. So eventually we got the kid through our program. I didn't even do the MRI on him. I read 3 MRIs that had been done at this big institute, and it was clear he had compression and very severe compression. So I had an interesting conversation with a mom, and she just didn't want to buy it was TOS. She says friends who's a neurologist, and she said it can't be TOS. TOS doesn't exist. And when I said, why don't you check out in your neck of the woods, Dr. Tracy Newkirk, and you and I, Steve, both know the quality of the person and the quality of the work he does. He's a gem for TOS patients.
Yeah.
The mom said to me, no, I really shouldn't. I had to ask, why not? She says, well, our friend said, Newkirk diagnoses everybody with TOS. My first response was just to say, look, this guy is as honest as the day is long. And if your son doesn't have TOS, he'll just tell you. He may not like it, but he'll tell you. But he does see a lot of TOS patients because they're not seen by anybody else. If you think it doesn't exist, you don't know the literature. And if you know the literature, you know that TOS exists. So who's seeing these patients? Well, in our area, one guy sees a lot of them. And she did see him, and they had a great experience with Tracy Newkirk. And the son got better and better over time with no surgery. I know he saw you. And eventually, a few years down the road, the mom sent me this really cool video from the local Oakland Coliseum. I think it's called O.co, whatever. And there was Kelly Clarkson playing, and one of her musicians doing a solo was this young man. And that's just the coolest thing in the world, to be able to help someone like that, right? So awareness, awareness and open-mindedness are really big when dealing with doctors and patients. And patients' parents have to advocate. If they really think it's TOS and they received an expert opinion like yours, Steve, or mine, or the doctors we work with, then sometimes they have to fight the system who says it couldn't be TOS doesn't exist, whatever. So the ones who empower themselves, patients who are asking questions here, ask questions and read and come to educational websites and find the people who are good with this. Empower yourself with that knowledge. That's what I always say. I'm going to interrupt myself here. We did have a question from Patrick who says, how do you get out of the circle of bad posture and pain? I think that's great for you.
Yeah, I think you have to control the pain first. So when I see a patient first is the exercises we're doing are lying down. There's some ways we use to support the neck and the arm and the legs. And so I'm trying to get sort of the posture part out of it temporarily and just focusing on the diaphragm breathing, relaxing the scalenes and decreasing the pain that way. It's hard to address the posture like immediately because I think there's just too much going on. This goes back to what we just talked about, Tracy Newkirk. He has a vest that he uses to kind of help correct the posture so that the patient doesn't have to do as much work. So I think it's these at the beginning, it's getting the pain down using some kind of a support, maybe the vest, or even just when a person's sitting, is just really using proper support for sitting. And then as they start to feel better, you start working on the postural issues. There's some things we use with a collar that I have. I don't want to get too deep into that because that's a whole thing. But I think getting the pain under control is probably the first step. But controlling the posture is ultimately what gets people better. Getting stronger is what gets people better. It just has to come at
Patrick
the
is
right
very
time.
smart, pointing out that when you have pain, that you assume a different posture.
Right.
When you assume a different posture, the pain gets worse.
Sure. It's like a reflex.
It's a circle of bad. And so we see it. If you bend your neck, your scalenes get shorter and then they get tighter. Then you have to hunch forward, roll your shoulders, your scalenes get shorter. And while I'm exaggerating, this is what happens to people and they can't break that bad circle. Patrick also asked another question, which I'm going to intercept here, about nerve EMG. He said nerve EMG is negative. Can one still have TOS? So Patrick, first of all, thanks for the really good questions. This is as good a question as we get in TOS. TOS, if I can tell stories, because I like telling stories about people, TOS was first described in the literature in 1818. That's 200 years ago. And it's a fascinating thing to read through these really old medical journals. But since then, there were a lot of docs and researchers who studied TOS, some of the biggest names in medicine, like Michael DeBakey. Michael DeBakey is the guy who created the MASH unit that we all know, that TV show MASH. But those things were amazing, and he created them. Halstead, Paget, just people who were amazingly famous in medicine for a lot of things, researched it. There wasn't a question about TOS. There were questions about what caused it. Many people found different methods to initiate the symptoms. But in the 1980s, a guy came along at the Cleveland Clinic by the name of Asa Wilborn, a very well-respected neurologist, and he took a bunch of TOS patients and did EMG nerve conduction tests on them. And he said, I don't see anything on the EMG. My conclusion is that all these patients are faking it. And the surgeons are encouraging them to fake it so they can do more surgery and make more money. Now, this devolved into a real catfight in the literature with, in particular, David Roos, a famous TOS surgeon in the 60s, who did a lot of pioneering work. He did transaxillary rib resections. He recorded the different types of fibrous bands and muscle anomalies in the thoracic outlet. And that hadn't been done really like that since the 1920s, where a guy named Law had found these things. So Roos and Wilborn went back and forth in the literature. Roos would say, if they don't have TOS, what do they have? I mean, they're just making up all this pain, or these patients who just decided to use a hospital and get surgery. Tell me what they have. And it went back and forth like that. And really what it boiled down to, Patrick, is that Wilborn had decided if patients didn't have a positive EMG, they could not have TOS. And he created 4 types of TOS: arterial TOS, venous TOS, true TOS, and disputed TOS. If you had a positive EMG and you had wasting of the muscles in your hand, which meant you couldn't use your hand, that was true TOS. Now, I would tell you that in every other nerve entrapment, doctors do not wait. I repeat that. They do not wait until you get atrophy in the muscles served by those nerves, because those muscles don't come back. It's a sign of severe nerve damage. We don't treat cancer patients by waiting for bone metastases to show up. We treat them before that. So Wilborn said, disputed TOS is the same exact patients. They have all the same signs and symptoms, but they don't have a positive EMG that I did, and they don't have this wasting of the muscles. Now, to my eye, number one, there's no proof that EMG finds TOS. I can tell you all the technicals. It can't even be performed the usual way. It has to be performed in a roundabout way to send a super strong impulse backwards up the arm towards the neck and then back out again. I can say number two, that there are very few studies that show during surgery, when you actually measure the EMG nerve conduction velocity at the exposed nerves during surgery, you do see abnormalities. And number three, I would argue very obviously that disputed TOS is just earlier TOS, before the patient has gotten so bad that their muscles have wasted away. But remember, with muscles in your hand waste away, not only is it almost certainly to be permanent, it's your hand. Okay? Do you use your hand? I do. Use my hands for lots of stuff, including pointing at my video camera. So I make light of this, but nobody would wait for TOS or any other entrapment neuropathy until the muscles are gone. You just don't wait that long. And that's what Wilborn was proposing. And if you didn't buy what he said, you had to use the word disputed TOS, disputed neurogenic TOS. Now, Steve, if I say, well, your skills are disputed, that's a pretty nasty thing to say to somebody.
Right.
You know? So when I talk to some doctors, unfortunately, they'll say, well, TOS isn't real. It's disputed. It's not based on science. You can have a negative EMG, and most TOS patients do. You prefer, if you were diagnosed with TOS, Patrick, to have a negative EMG because you don't have enough nerve damage yet for the EMG to turn positive. So it does not eliminate TOS. You need a good specialist who has experience seeing these patients. We can hook you up with teleconsults with people like Steve or Tracy Newkirk or others if you don't have a local doc. And if you want to email me on my website, we're glad to connect you with the docs we know in your area. So we're glad to help out. Of course, we do that for free for lots of patients. I hope I answered up that question because there's a really long answer. Steve, do you have anything else you want to throw in here after all our questions? Oh, here we go.
The only thing
Steve, if you look at the bottom, we have a lower third that says, Amira Sharif said, I have plenty of atrophy and a normal EMJ. So there you go. All right. The EMG doesn't do it. Shouldn't be considered absolute in any way. Marion, thank you for coming back. TOS patients are told quite often that they don't have TOS because they have a negative EMG, and that's really true. Steve, I don't know in your experience, you hear about patients who say, I didn't get the diagnosis forever because I have a negative EMG.
Oh, all the time. And actually, I did hear a patient just a couple of weeks ago tell me the doctor mentioned disputed TOS. I mean, didn't believe in TOS, and this is just a couple of weeks ago.
What day is it? What year is it?
Right. So
I'm being facetious, but I will tell you that I think it's intellectual laziness. Anybody who knows what PubMed is, you go to PubMed and you search for articles on a subject. If you go there and you search on Thoracic Outlet Syndrome, you'll find it's probably up to 3,000 papers by now. I told you the history about it's been there for 200 years. Some of the greatest names in medicine have researched it, totally not thinking it was disputed, and found amazing things. It's not disputed. It's real. If your doctor, if he or she doesn't want to believe in it, they don't get that choice. They don't get the choice to believe or not. It's a real disease and it affects you. So talk with your doc, try to work it out, or find another doc and we can help you. I'm also told to promote our next event on March 16th at 4:30. So I think that's a few weeks from now, March 16th. I know the speaker is really excellent. I can say that in complete honesty. My kids aren't around to teach me about it, but I will be talking about the brachial plexus and thoracic outlet syndrome. I'll just make this point before the talk. I see lots of radiologists who do a brachial plexus MRI, and I don't think that's nearly as helpful because the disease is not in the brachial plexus. It's a disease of all the structures around the brachial plexus that cause this damage. Steve was talking about the spaces and the scalenes and the nerve gliding. Those are all tissues around the brachial plexus. So my talk will be focused on some parts of the brachial plexus, but more about its role within TOS. It's not the causative agent, and the disease is not centered in the brachial plexus. I hope it'll be a good talk, of course. I'll do my best. Steve, people can contact you if you want. The usual way, they contact our website and we connect them with you.
Sure.
You do teleconsults that have so far been working very sweetly. You're glad to talk to patients just to get the lay of the land to start with, see if your services are useful.
If I can help them, yeah.
Awesome. And I can tell you that there are plenty of very experienced docs around here of all stripes who refer patients to Steve because of his expertise, his relationships with patients and their doctors, and his experience. You just can't substitute for all that training with Geeter and then where Steve has gone beyond that. So if we have no further questions, Steve, thank you again. It's always a pleasure to have you on here.
Yeah, so happy you asked me to come. I mean, I'm just here to help people, and I'm blessed to have met Peter and learned what I did from him and carried it forward. So I feel it's a responsibility.
Patients always say tremendously good things about you, and that's why I keep encouraging patients to reach out, get in touch with you. They will love you as much as I know they will. We do have another question just came across our screen here from Patrick. Thanks again, Patrick. Thank you very much. They find my case very hard, but they won't do an MRI to exclude it. I had TOS symptoms, but no final diagnostic. I have both shoulder instability, and I wish a TOS specialist. I'm guessing the last sentence means you wish you had a TOS specialist. So I also believe that Patrick is in the Netherlands. Patrick, you can send us another question if that's true. I want to say this. We're lucky with technology that we have. We can connect you with some of our expert docs. You know, doing a workup over a teleconsult, it's not the same as being there physically and having hands-on. But I think people like Steve, Tracy Newkirk, I know because I talked to him, and some of our other TOS specialists around this country, they're adapting to it. They understand that people may be far away, may not be able to travel, and so they can still do an excellent job. And I think if you contact someone like Steve or Tracy Newkirk through our website, we're glad to connect you. It may just take a talk to find out maybe you don't have TOS, maybe they suspect you have something else, or maybe make you feel a lot better because they believe you do have TOS. So I strongly advise, get in touch with us. Let us put you in touch with some of our experts who are learning how to use this teleconsult tool, and probably get you 80% of the way there. A couple of comments from other people we can all see on the bottom third. I want to thank you all for attending. I'm really happy when Steve can connect with so many people because these things are very challenging. Steve is one of the few people who does this sort of thing, and he does it wholeheartedly. His patients love him. He has great results. Talk to him if you want to, or get your physical therapist involved and expose them to this so they can learn more about Steve's method. Thank you, Marion. Thank you, Patrick, for all the questions. Thank you, Aaron. Good to see you again. And we'll have our next talk on March 16th. It'll be me. Any other questions, please send them to my website, tosmri.com. You go to the last menu on the right, which is, I believe, News and Education, and go down to Contact Us. And then you can send me your email, phone number, and a brief question, and we'll get back to you and set up whatever you need as best we can help. So Steve, always great. Again, I say that because I mean it. Thank you very much.
Yeah, thank you. I appreciate it.
And keep doing your great work. And thank you everybody else for attending. We're really glad you could come.
Thanks.